Good morning, everyone, and welcome to the second in the series of educational webinars from DC Primary Care Association. Hope everyone is well. We have a couple of folks on the call, so we're going to go on and get started. We're very excited this morning about just our topic, serving the healthcare needs of special populations. And we know that this is a challenge in our health centers, and it's also a priority with the Bureau of Primary Health Care, that we as the Primary Care Association work closely with our community health centers to leverage resources and strategies around addressing the needs of special populations, especially specific to folks living in public housing and our homeless population. We are very excited to have our partners with us on this morning. Dr. Astral Webb, who's the Director of Health and Family Services at North American Management. Dr. Webb currently oversees the activities of two funded national cooperative agreements to provide training and technical assistance to the safety net providers serving residents in public housing and seniors in special populations across the country. So we're very excited to have Astral with us. I'm going to actually turn it over to Astral so she can begin the presentation, because we want to share information, but we also want to hear from you and capture all of your questions. Just to let you know that this presentation is being recorded, so you'll be able to go back and share it with other staff that were unable to be a part of the session on this morning. So I'm going to turn it over to Astral and we'll get started. Good morning, Astral, and welcome.
Thank you so much, Gwen, for that wonderful, warm introduction. And of course, it is a phenomenal opportunity to be working with you at DCPCA on such a very important topic. This is a special population that sometimes is forgotten, and truly, as safety net providers and community health centers serving these disadvantaged populations, it's really important for you to understand what the needs are for special populations, who these populations are, and how you can better help serve them. So as Gwen alluded to, I am the Director for Health for the National Center for Health and Public Housing and the National Center for Health and the Aging, which are two corporate agreements funded by HRSA. As this presentation is really tailored to meet your needs as community health centers and safety net providers in the District of Columbia, we will make this presentation very broad so that you understand more about the special populations, and if you are currently not funded by HRSA to serve the special populations, how you can recognize them and start capturing that in your data. So first of all, we would like to, again, by definition of special populations, today we will be using HRSA's definition, and HRSA currently identifies as groups of special populations as the migrant and seasonal farm workers, those individuals living in public housing, and individuals and families experiencing homelessness. So these are the three main special population groups that you will have the opportunity to learn more about today. This is a very general overview, and we will do a more specific series on each of the populations at a later time in the fall with DCPCA. So you can look forward to more information at that time. So I want to share, first of all, a little bit about each of the special populations. But in general, let me give you a quick overview of what we have noticed from the UDS data that's provided by HRSA. Over the past 10 years, there has been a significant increase in the number of special populations served by community health centers and safety net providers. In the homeless population in particular, the numbers have literally doubled over the past 10 years. For the number of migrant and seasonal farm workers, that number has increased by about 25%, and residents in public housing by roughly the same. And so we see that through the passage of the Affordable Care Act, through the passage or the new revisions under healthcare reform, we will continue to see the number of special populations being served increase. And so for you, it's a phenomenal opportunity to increase your enrollment number for the patients that you serve. So the first population we will focus a little bit on is the migrant and seasonal farm workers. These are a migrant or seasonal farm worker is someone who has temporarily established a home for the purposes of farm work employment. And so they tend to live in very poor living conditions as well as working conditions, which really results in many of the healthcare issues that they have. A lot of migrant populations, there are multiple families that live together or individuals who are living together, and a lot of times that accounts for some of crowding that we see, and which is why we see a lot in terms of healthcare issues. There is frequent mobility of this population. They move from place to place in order to seek work. There is a very low literacy population, and of course languages and cultural barriers actually exist that hinder their access to primary care. And so as you're working with a migrant or seasonal farm worker population, these are some of the factors that are very important to consider so that as you provide your care, you can really reach this population. Now, the number of health centers that have served the special populations across, according to UDS, there are about 860,000 farm worker patients who have been seen through community health centers. And these, most of them, are below the poverty level, 100% below the poverty level, and so they are populations that you would consider when you're looking at your sliding fee model. Most of the migrant and seasonal farm workers, when they do look for health care, they're primarily seen by family physicians, and then pediatricians for the children of the farm workers. And then there is a great significant need for obstetrics and gynecology. And then internists, and then general practitioners. So those are the orders of which the migrant farm workers actually will go to a doctor. And this is according to what we've already seen happening across the health community. Primarily, about 50% of the migrant seasonal farm workers seen by health centers have been uninsured. About 36% have been on regular Medicaid, and this is what we are seeing in general in terms of reimbursement for you as health providers. Now, in the District of Columbia, according to UDS, we've only seen 103 migrant patients being seen, and this is of course in 2011. Well, one of the reasons that we believe this is the case is because there are not a lot of farmlands in DC, and that's one of the reasons that we're not seeing it. But it doesn't mean that there are only 103 migrant farm workers. I believe there are many, many more. It's just that the data is not captured by community health centers or safety net providers. But there are a number of, we've seen a number of community gardens coming up and so forth. And so we do know that there may be more. So this may be a population that you will want to consider capturing your data on. When we look at the key health issues for farm workers, most of them are related to the occupational health and safety hazards because of the environment, being in the outdoors, and working with farms and the animals on the farms. And so we see a significant amount of cardiovascular disease as well, asthma, TB, and of course oral health issues. It's really big in this population, mainly because of the poor nutrition and the lack of resources to seek care at an early time. And then of course you get numerous infectious diseases because of overcrowding and poor sanitation. But we also see a lot of depression and substance abuse in this population. So it's important to know that does exist. When we look at the maternal and child health needs, we see that many of the health issues that are common amongst the women and children are due to a lack of prenatal and postnatal care. You may have over-immunization or under-immunization of children. Because of the pesticides that are used on the farms, there's a lot of pesticide exposure. So a lot of individuals also develop upper respiratory infections, diarrhea, we see anemias, lacerations, and of course complaints of headaches and dizziness. In fact, that's one of the reasons that the chief complaint as the patients are coming to the doctors. So always think of some of those, just the conditions in which that person may live or work. If it's occupational threats, then you would want to consider those in your diagnoses appropriately. One of the best practice models that's used in the farm worker population is the promotora model. And a promotora is the person who leads advocacy for their community's health. And in some of your community health centers, you actually call them community health workers. And so they target the farm worker labor camps and rural areas where farm workers may be. And in some states where there are border communities, they also provide health care for those individuals as well. Through the promotoras actually participate in a lot of health training and they are certified, and they are committed to bringing those individuals into your community health centers for care if that is necessary. And they tend to share information with their community members. Because they most of the times are members of that community, they're able to engage the others in their communities about the importance of seeking care and the benefits of care. So a lot of times they share their own personal experiences and become an advocate for you as a healthcare provider. And of course, we see a lot of the promotoras who are actively involved in addressing mental health and substance abuse and stress issues. They really talk to the farm workers about these different issues so that if it's impacting the lives of their families, they're a little more aware, and they are taught ways that they can reduce those amounts of stress. In terms of health outreach, some of the common methods that we've seen with this particular population is that for recruitment, a lot of the farm workers are brought in because they attend, or you may be an outreach individual has reached out to scouting camps where a lot of farm workers are recruited. And so they are constantly looking for individuals who may not have access to care and documenting this information. In addition, sometimes the promotoras also help with home and field visits. They reach out to the farm workers either at home or at their places of employment, wherever they gather. And they also, there are a number of agencies that serve farm workers. So it's a great way for the promotoras or to actually contact some of the agencies like the Employment Security Commission or any labor organizations or Head Start programs, because many of the children from the farm worker population are enrolled in Head Start programs. So these are some of the places that you can find more patients if you're looking for this particular population to better serve. It's a great way of recruiting some culturally and linguistically appropriate staff to work with this model. These are some of the organizations that you may want to look for and recruit this staff. And then we have a number of corporate agreements, a number of resources where you can find a lot more information in terms of how reaching farm workers and migrant and seasonal farm workers. And so I would like to share one of them here with you, and it is the Health Outreach Partners. So please feel free to visit their website, and you can get a lot more information on what they do in terms of outreach. And then you should also look at the Migrant Clinician Network. And this one encompasses, you know, expertise and resources from 5 different national corporate agreements that provide expertise to you as health centers on migrant health. So the second population we're going to talk about is the homeless population. And I know all of you are very familiar with this population in the District of Columbia. But a homeless individual is someone who has no permanent housing, but who may live either on the streets. They sometimes stay in shelters or missions like churches, or they have single-room occupancy facilities that may house a homeless individual. Some of them live in abandoned buildings or vehicles, and any unstable or non-permanent situation, that individual is classified as being homeless. We see a number of chronic diseases which are difficult to manage in this particular population, and when there are stressful circumstances surrounding that individual, their chronic conditions are even worse than what we usually see. The acute problems themselves may be more difficult to heal, especially simple things like cuts, because there is no place for them to really rest or recuperate, and they are exposed in the outdoors where they're really not protected. So the homeless individuals in the District of Columbia, as of 2011, about 20,633 people were identified as experiencing homelessness in the District of Columbia. This has been identified as the 5th largest homeless population in the country, especially amongst the large metro areas. So in the District of Columbia, we know there's truly a significant opportunity to serve a number of homeless individuals. Most of them are tend to be more males than females, and of course, you know, 90% of those individuals are 100% and below the poverty level because some of them or most of them do not work. This is a high uninsured population, and when homeless individuals seek doctors' care, they primarily are seen by family physicians, followed by internists because of the number of chronic conditions, and general practitioners, and then there are a significant number of pediatric visits that we've seen through the health centers serving the homeless populations. And of course, there is a great need for pre- and postnatal care as well. So some of the key health issues that we've seen amongst this population include mental health, substance abuse, foot problems and calluses, especially for diabetic patients. This is a great problem. And then we have a number of lung conditions, bronchitis, pneumonia, upper respiratory tract infections, and then we see a significant number of wound and skin infections, and of course hypothermia in the very cold winter months. Due to the stress of living on the streets, clearly these individuals are not protected, and they really are exposed to every possible health condition that can impact them. So some of the key issues when we look at maternal and child health include domestic and sexual abuse. A lot of these women who live on the streets are really just prone to being abused in several ways. And there's a high rate of emotional and behavioral problems that are seen in homeless children as a result of the environment around them. When we look at some of the best practices in terms of how do we outreach the homeless population, we have seen that for the mobile health unit is the way that most of the health centers have been successful in reaching that population. Not only are these units targeting displaced people who have no access or limited access to your actual health center sites or your clinic sites, but they also provide an integrated service of not only to meet the health needs, but also the social needs of the homeless individuals. Most of the clinical teams use a multidisciplinary approach where a lot of times there is a nurse case manager on the team and on every team. And this not only increases access to and the use of the community services, but also helps in enrolling those patients in insurance programs if they qualify, especially now with the new exchanges. There is also, many of these health clinics, mobile vans also assist the immediate and the basic needs of the homeless individual. When we look at the homeless team, I just want to touch back on this a little bit. Make sure that you can build a team that can provide crisis assessment and interventions. These teams should be able to focus on mental health crises and really be able to target the streets and the homeless shelters to find a lot of these individuals. And again, that team is very, very important to have. So usually you would have that nurse, the case manager, the social worker, the counselor, as well as the community health centers on top of your network safety providers. And that team approach is really the most important part of providing that care for the homeless individual, because there is no guarantee they will come back. But having your outreach workers constantly follow up with them whenever they can, that really helps in your model to be successful and provide that care that's necessary. In D.C., when we look at the health outreach that is in D.C., as part of the homeless services strategy, the D.C. Department of Mental Health helps temporarily and chronically homeless individuals who may have mental health illnesses and keep them off the streets and keep them in a more safe, decent housing where they can get the support that they need. The downtown D.C. Business Improvement District actually has a 4-person clinically based outreach team that provides street-level interventions. As well, they also have a homeless outreach service team, or otherwise known as HOST, who works closely with the downtown homeless service team and recognize and engage those individuals who have mental and addiction challenges. And to get more information on what's happening with homeless health care, and how you can provide better care for the homeless organization, we would like to refer you to the Healthcare for the Homeless Council, and their website is available, and you can contact them directly. They are right now the national corporate agreement responsible for helping you with outreach to the homeless populations. And I know many of you have already had some kind of contact with that organization as well. And then we come to our third population, the residents in public housing. These are individuals who live in the U.S. Department of Housing and Urban Development, which we call HUD, and they are funded. They live in funded rental housing for eligible low-income families, the elderly, and persons living with disabilities. In residents in public housing, we've seen a high prevalence of obesity, asthma, diabetes, hypertension, cancer, heart disease, HIV, and STDs amongst many of the highest reasons why residents actually are seen by doctors. In the District of Columbia, there are 8,369 public housing units available, and each of those units tend to have about 2 to 3 individuals at minimum. And so there is a great need to serve residents who live in public housing to meet their health care needs. When we look at the number of individuals being served, this population, 83% of this population live below 100% or below the poverty line level. Many of them work in the very communities. They are the janitors, the teachers, the medical assistants, the waitresses in many of our businesses here in the District of Columbia. So it's really important to recognize that even in those small businesses, many of those individuals that you're seeing, they probably live in public housing. And if they're one of your patients, then it's a great way to document that you are truly serving another special population. Most of the residents who go to the care, they're really seen primarily first by family doctors. There are a lot of pediatric visits, and then they go to see internists and then specialties. Now, what we do see is that there's a significant lack of subspecialties actually for all of the special populations. So as you are designing your health center or your facility to accommodate these special populations, you would want to start looking at what other organizations in the District of Columbia you can possibly partner with as a referral service. Most of the residents in public housing are 50% of them are covered under Medicaid, and what we've seen with some of the other health centers, about 33% are uninsured. And so, again, this is a population that potentially you can reach. So when we look at the key health issues serving residents in public housing, like I said, we see hypertension, high cholesterol, diabetes, poor dental health, and asthma as some of the greatest key issues. So always look for these things here in the District of Columbia. There's a lot of it with the number of residents that we see. When we look at the most promising health outreach practices, we know that we have to use a community support strategy. You have to be able to identify community leaders, those who are engaged with residents in public housing. They tend to come from the resident councils. Each of the public housing units are run by a group of residents who form that leadership leg, and they are sometimes that community's leaders as well. So try to identify your community leaders. Make sure that you partner with your housing authority. That's really important for the buy-in, for you to be able to provide that access to care for their residents. And then, again, address any opposition promptly. Residents in public housing tend to be multi-generational family members. They tend to have a lot of mistrust for doctors because they don't know if you're studying or doing a research project on them or if you're truly there for their care. So it's really important to let them know. If you, for those of you who have special populations, as you're recruiting your board members for your health centers, really think of those consumers from those special populations as well as possible board members to help bridge that gap and reduce those barriers. When we look at some of the tools that in terms of providing outreach to these residents in public housing, these are some of the things that have shown to work best. Use of handouts, which are written at a very culturally sensitive and linguistically appropriate manner. Make sure that the information is very clear, that it's at a lower level grade. Many of the fact sheets and informational sheets that network providers provide tend to be at the 8th grade level. And what we've seen with residents in public housing, sometimes you have to consider that level being in the 5th grade level. Always pass out flyers on health promotion, educational type materials. Have welcome committees going out and doing outreach and welcoming them to your health center or your clinic, wherever you are. And again, make sure that the language that you're using in all of your publications and all of the ways that you're trying to attract them to your health center are linguistically appropriate for them. Giveaways, residents love giveaways, and it is a great incentive. So as you're doing health fairs, always consider the little free giveaways if you can. That really helps them. And then anytime they see it, it's always a message to them to remember to go see their doctors. When we look at some of the methods of outreach, we've seen this work really well with residents, door-to-door outreach. They like a lot of in-person outreach. Then you have the floor captains for each of the units. As you're looking at your resident councils, look for those individuals to get your buy-in. They like group activities, so big community events. Some individuals want the actual one-on-one, especially for the disabled populations that reside in public housing. And then word of mouth, there's nothing like that for you as providers. If you're providing care for one person and they're pleased and they got the help that they need, residents are really great about spreading information word of mouth. So, and if it's not favorable, they will also spread that word as well. But the good thing about it is word of mouth is always a great method to reach residents in public housing. And then again, the mobile units, they provide that on-site care, that integrated care with residents in public housing. Remember that your model should be integrative, very family-based, because you are dealing with multi-generational families, and provide not only the preventive but also that primary care as you do. So I just wanted to let you know that currently the Bureau HRSA funds 63 community health centers, and they're located in 25 states and Puerto Rico. And currently we only have one public housing health center program here this year enrolled as a public PHPC site in the District of Columbia. And so there is a great need, as I've shown you before, having so many housing authorities, there is an opportunity for there to be potentially more public housing type service providers in the District of Columbia. So for more information for this, for the public housing population, you can feel free to reach us here at North American Management through the National Center for Health and Public Housing. And we have a number of toolkits and resources available. Like I've said, for all of the special populations, all of the NCAs have provided numerous resources that can help you better reach those residents in public housing, your homeless individuals, and the migrant seasonal populations. So I do want to thank you so much for your time, for listening, for learning. I hope that you learned a lot more about special populations that you did coming on to this call. And at this point in time, we'll open the line to any questions or comments.
Do we have any questions?
Sure. Devin, can you also let me know if anyone has any questions in the queue?
No, ma'am. No questions at the moment.
Okay.
Well, Ashley, let me ask the folks on the line, what is your current experience with working with the homeless population in your health centers? What kind of strategies have you been looking at? And what are some of the concerns that you have in trying to serve the population of the homeless and residents in public housing here in the district? Anyone want to share what their experiences are?
Hi, Gwen. I apologize, but I believe that the participants they cannot access us directly by phone.
Oh, okay.
Devin, are you on the line? They will probably have to respond by the chat feature.
Oh, okay.
That is correct.
Oh, okay. Oh, okay.
But absolutely, we think that would be really great to learn more about some of the challenges.
Right. If anyone wanted to, oh, okay. If anyone wanted to just put a message in the chat box, it would be very so for us to hear back. And this is just the beginning of a series of trainings that we would like to do around special populations. And I know some of the health centers have a long history of serving these populations, and so we definitely want to share best practices. Our goal is in the fall to have a face-to-face forum, either a part of our annual meeting or aside from our annual meeting, but we just come together and strategize because we know that Unity Healthcare and Elaine Ellis have focused on those particular populations, and so opportunities to share and learn. If there are no questions, or if you just want to shoot them to me and we can follow up later, that will be fine, and we'll just have some closing remarks from Astral, and I want to thank everyone for participating. It looked like several other folks did jump on the call, and as I stated when we started, that this will be recorded, and we will be contacting you and following up. There will be a survey to see just what you thought about the information that you received on today, and definitely want you all a part of the planning for a fall forum. So thanks again for your time, and I think this was some great information. So Astral, you want to have any parting words?
Sure, and I do want to just reiterate that there is a phenomenal opportunity to serve special populations here in the District of Columbia. And so I want to encourage you. I look forward, Gwen, to the opportunity of working with DCPCA and really helping bring some of those models and best practices together, and really help address some of the challenges that the health centers may have to serve these populations. So again, thank you for the opportunity, and I look forward to continue working with you in the fall.
All right, thank you all, and everyone have a great afternoon and stay cool. All right, take care.
Thank you.
Bye. Bye-bye.